Talk is the basics of ocular surface examination. Is it really essential? By Dr. Sara AlHilali. Dr. AlHilali did her ophthalmology residency and cornea fellowship at the world-renowned hospital KKEsh in Riyadh. She was chosen as the resident of the year, and she's used to be the educational activity coordinator for the fellowship. She also did a 6-week internship program at the World Health Organization for the prevention of blindness in Geneva. She has more than 13 publications, which is very impressive in her short career. Without further ado.
Assalamu alaikum, everyone. Can you hear me? Assalamu alaikum. Good morning, everyone. Thank you, Dr. Mahmoud, for this introduction. Again, my name is Sara AlHilali. I'm an associate consultant at King Khalid Eye Specialist Hospital. And today I'm going to talk to you about the basics of ocular surface examination. So as we all know, ocular surface is a system of physical structures working together to provide, protect, and maintain the smooth refractive surface of the eye. So these include cornea, conjunctiva, lacrimal glands, and meibomian glands. The function of each of those structures integrated or linked by innervation and by the endocrine, vascular, and immune systems. So as such, any dysfunction of any of these structures would lead to alteration in the refractive surface of the cornea, contributing to signs and symptoms of ocular surface disease. So we're going to through each of these structures. So it is important when looking at each of those structures to examine both structure and function. So starting with the eyelids, it is crucial to examine the patient in ambient light, looking at the face, looking at the skin of the lids, and then noting any skin changes, such as dermatitis, rosacea, the eyelid position, any abnormalities in the lashes direction, trichiasis, distichiasis, and of course pay close attention to the lid margin, looking for any irregularities, telangiectasia, signs of meibomian gland dysfunction, basically. It is also important to note the blink rate, as well as the presence or absence of any lag of thalamus. Look for the Bill's phenomenon, and definitely check for the lid laxity, especially in cases of floppy eyelid syndrome. Going into the tear film assessment, it is important to do that before installing any drops, as we know, and paying close attention at the tear meniscus height and the presence of any draperies, as foamy tears might indicate meibomian gland dysfunction. Pay close attention at the tear breakup time, as any reading or measurement below 10 seconds is considered abnormal, of course with the use of fluorescein staining, and the position of the upper and the lower puncta, as any ectropion of the puncta can lead or play a crucial role in dry eye disease. And definitely check for any punctal stenosis. There are many tests to examine or assess the tear film, and I'll keep that to the next talks. However, the two most common tests used to assess the tear production are the Schirmer test and the phenol red test. As we know, Schirmer test is used to test both basic and reflex tearing, and we know that there are 3 types. Type 1, checking both basic and reflex tearing, and then type 2 is the one with anesthesia to check the reflex tearing, and then lastly is type 3 with the nasal stimulation to check for reflex alone. And it is claimed to be variable. The results are variable and somewhat unreliable. Coming into the phenol red test, in comparison to the Schirmer test, is considered to be less uncomfortable and more specific, where a special cotton thread is impregnated with a pH-sensitive dye, and then it turns from yellow to orange when wetted with tears, and then you can measure it after 15 seconds. Going into the conjunctiva, it is again helpful and to check the patient or examine the patient in ambient light again before taking him to the slit lamp, and examining all quadrants of the bulbar conjunctiva, looking for any follicular papillary reaction, and then under the slit lamp, pay close attention to evert the upper lid as well, and look for any lesions, pigmentations, any adhesions, in the form of symplepharon and caloplepharon. There are many staging systems for that, but I did not include them due to the limitation of the time. However, it is crucial to use a standardized method of staging those adhesions to better follow up your patients. And then definitely look for keratinization, as mentioned by Dr. Mahmoud in the previous lecture. And measuring the fornix depth is crucial, especially the lower fornix, as any reading below 10 millimeters is considered worrisome. So the cornea, again, we pay close attention at the limbus. The early signs of limbal stem cell deficiency in the form of loss of the palisades of Vox, the early staining pattern, as mentioned before, the vortex staining pattern of the cornea. Look for any corneal opacities, irregularities, lesions, vascularization, and how many clock hours of vascularization. And then look for the presence or absence of any thinning and conjunctivalization of the corneal surface. Again, corneal sensation can be assessed grossly or more subjectively using a wisp from a cotton tip applicator. However, a more objective method of checking the corneal sensation would be using estiometers, as we know. There are a number of special tests to further elaborate or further assess the ocular surface, such as ocular surface staining, T-osmolarity, impression cytology, and different ocular surface imaging modalities. I'll just go or touch on a few of those. So again, as we know, the three most common types of stains that we use are the fluorescein, rose bengal, and the lemon green. Fluorescein comes in many forms, or in two forms to be specific, the drop solution and the filter strip, and it is mainly used to stain defects in the cornea and the conjunctival epithelium. Rose bengal, however, stains dead and conjunctival cells and cells that are unprotected by the normal mucin layer, so it is important or useful in assessing dry eye disease. And it actually stains the conjunctiva better than the cornea. However, as we all know, it is a bit irritating to the patients. As you can see on the photos to the right-hand side, the rose bengal staining lesions of ocular surface squamous neoplasia. Lemon green has a similar mechanism to the rose bengal, however, less irritating, so it would be useful. Impression cytology is a very useful method where we use a cellulose acetate filter paper applied to the ocular surface and then removed and examined further under a microscope for histological, immunohistopathological, and molecular analysis. It is a non-invasive method and it has many applications, including limbal stem cell deficiency, OCP, and OSSN. You can see on the right-hand side, the top image is an impression cytology showing you the goblet cells that are reddish pinkish in color, indicating conjunctivalized corneal surface and limbal stem cell deficiency, whereas the bottom image on the right showing you dysplastic squamous cell. Mebomography is another non-invasive method that shows you the meibomian glands in vivo, and it is useful in the diagnosis and management of meibomian gland dysfunction. And you can see the dropouts of the meibomian glands in the top right-hand image, and the engorgement and inflammatory condition in the bottom image. Lastly, I just wanted to touch on the anterior segment OCT. It has many useful uses in ocular surface diseases. It is a non-invasive method, produces two-dimensional high-resolution image that can show you like a cross-section of the ocular surface. And the applications are many. I just listed few here, such as in conjunctival pterygium, melanoma, OSSN, and dry eye disease. As shown in the top right-hand image, this is the classic appearance of OSSN with the abrupt transition from normal to abnormal hyperreflective epithelium. Thank you.
Thank you.